what Dr. Nolan and I have always said is, in residency, people love the high tech, the CTs, the MRIs, the interventional. They don't really like plain films, and they always start with plain films. You can see a lot of stuff on radiographs that you'd be surprised if you really look for them. And so I'm going to show you how I interpret the KUB and then show you some cases. I got nothing to disclose. I want you guys to remember 4 very important concepts to look for in every KUB, to review the normal anatomy, and to help you guys recognize abnormalities. The normal anatomy, when I start, this is a KUB. KUB stands for kidney, ureter, bladder. It will not include the hemidiaphragms. Okay, it will not include the hemidiaphragms. It's going to be from the kidneys, and it should go below the pubic symphysis. But this is the KUB, and this is the erect view. The erect view, what we do on an erect view, we're looking for air fluid levels. We're looking for free air into the hemidiaphragms. That's the important part of the erect view. I always start with the bones. I always go spinous process, spinous process. If there was a laminectomy, you would go spine, 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 spine. Where's the other spine? You see a blackness here and you'd recognize it as a laminectomy. If you don't really look at a systematic approach, you can miss a lot of things. Then I go sacrum, look at the SI joints, look for sacroiliitis, look at the arcuate lines, make sure there's no fracture, make sure there is a coccyx, a lower sacrum and a coccyx. I look at the iliopectineal line, make sure there's no interruption in that, no fractures. I go around the iliac wings. I look at the greater trochanter. I look at the femoral heads, look for ADN, look for developmental dysplasia of the hips, look for bad degenerative changes or whatever. Then I come and I go, or I go real quick, look at the ribs, and then I go white calcification. Here's the renal shadow, the right renal shadow, the left renal shadow. Look for kidney stones. About 10% of gallstones will calcify. About 90% of kidney stones will calcify. So you really want to look for white calcifications, and then you want to look for white calcifications anywhere in the expected location of the ureter. Go all the way down to where the bladder is. They say that if you get the ischial spines and you draw a line, calcifications below that are usually phlebolysis. Phlebolysis are classic round calcification with a central lucency, but they don't always look that way. But the lower, if they're below the ischial spine, the line, they're probably phlebolysis. If they're above it, they could be ureteral stones. Then I do the same thing over here. Then I come on and I look at the bowel gas. I go colon, I look for any dilated colon. I'll tell you about the measurements and everything. I look for mass effect. And here I look at I would play with the window and I would look at the lungs, make sure there's no pneumothorax, make sure there's no lung mass, make sure there's no pneumonia. A pneumonia that touches the diaphragm can cause abdominal pain. Look for here, look for anything wrong with the heart, look for the free air. Again, look for calcifications because now we got the upper abdomen, the hemidiaphragm. And then again, look for air fluid levels. So the big 4 processes that you should look on every KUB are stones, bones, mass, gas. See, they rhyme. Stones, bones, mass, gas. So we'll start with stones. This is kind of windowed so you can see these, but here we have 2, 3, 4, 5, 6, probably 7 rounded calcifications with central lucencies in the right upper quadrant. These would not be classic, they look like they're bunched together. This would not be classic renal stones, but the gallbladder lives here. These are gallstones. About 10% of gallstones will show up. Here is several things going on. Here we have multiple calcifications in the right upper quadrant. These are all gallstones. What is this called right here, Yemisi? Staghorn calculus, absolutely. If we did an IVP or a CT and this kidney was non-functioning, what is that called? With a Staghorn calculus, non-functioning kidney, there's a lot of fat in this kidney. XGP, xanthogranulomatous pyelonephritis, especially Proteus mirabilis. These are other calcifications that are in the kidneys. Guys, this is the Psoas shadow, This is degenerative changes, degenerative disc changes, degenerative changes. So you can see multiple calcifications, gallstones, the Staghorn calculus, and other renal calculi. Here, these are tomograms when we used to do tomograms with IVPs. This is the right renal shadow. This is the left renal shadow. This is the psoas muscle. This is the psoas muscle. The kidney's axis should be the same as the psoas muscle because they live on the psoas muscle. If the superior poles of the kidneys are more deep, more posterior within your body and more medial, your inferior poles of the kidneys are more anterior within the abdomen and more lateral. So the kidney should have this axis. If they're more straight or more like this, that's your horseshoe kidney. So here, there's no contrast given to this person. These are all calcifications, but where do they look like they're calcifications in? Are they in the calyces, or are they in the papilla, the pyramids? This is medullary nephrocalcinosis. Medullary versus cortical nephrocalcinosis, which one is by far the most common? Medullary by far, like 85%. Medullary nephrocalcinosis can be seen with medullary sponge kidney, renal tubular acidosis, hypervitaminosis D, milk alkali syndrome, anything, hyperparathyroidism, sarcoid, senile osteoporosis, multiple myeloma, any oxalosis, any condition that increases your serum calcium will make your urine calcium go up and can give you medullary nephrocalcinosis. Sickle cell patients can get it. Patients on Lasix can get it. There's a big, long differential for this. Cortical nephrocalcinosis has a very short differential, but this is classic medullary nephrocalcinosis. And on an ultrasound, where you normally see the black renal pyramids, they'll be white because of these little tiny calcifications. This is an excretory urogram, an IVP, when we used to do them. We don't do these anymore. You could get an image just like this when they do a CT, and afterwards they get a KUB. You could see the nephrograms, the excretion, the ureters. Here's the urinary bladder, and here's this large calcified looking thing. And if we really magged it up, what do these things look like? Molars. This is a mature teratoma. They still take them out because there's a chance of later on turning into a malignancy. But these are teeth. These are teeth. In ultrasound, the most common thing that shadows is hair. But teeth can, if they have teeth, that'll shadow. Bone will shadow. But these are teeth. If you see teeth in the patient's pelvis, like this, and that's a mature teratoma. Here we have this huge, what kind of description would you call it? What kind of calcification? A big popcorn type calcification? What is popcorn calcification? When we say that, what are we normally talking about? Uterine fibroids. So yeah, this is a huge uterine fibroid. And if for the students, if you guys have patients with uterine fibroids and they're bothering the patient, you don't have to have them have a hysterectomy. You can consult interventional. They can go and embolize those fibroids and help relieve the patient's pain and bleeding and stuff. You always got to look for calcifications, and sometimes it's really subtle. There's some calcifications in here, and if you really magged it up, what does this look like? Anybody know what this calcification thing looks like? What does this look like? A skull, there's spine, there's a little arm. It's a fetus. We don't like getting KUBs or pelvic x-rays, and this was a surprise because especially the first trimester. If you have a patient that's pregnant and they're having chronic back pain and they don't have a cancer, they weren't in trauma, they're healthy individuals, wait till the baby's born before you do the lumbar spine. Lumbar spine series has a lot of radiation to the ovaries and to a fetus. Barium enema has a lot of radiation to this area. So if they're healthy with no cancers or significant trauma, and they have low back pain chronically, give them whatever you need to, rest, and then back strengthening exercises. You can always work it up later. If the fetus is older, after the first month, you could do an MRI, but I would probably not do a plain film. But yeah, we don't like seeing a fetus when we didn't expect it. This is when the physicist might have to get involved and decide how much radiation this little fetus get. This is windowed. This was an old image, an old x-ray of Peter Myers. This is an old lady. See this? What do you think that this could be? Look, what do these kind of things look like, kind of, maybe? Bone, maybe? Huge. This is like a old postmenopausal woman. This is called a lithopedion, a stone baby. This woman, when she was of childbearing age, she had an ectopic that was probably in her peritoneum, and it died, and it just ossified and calcified, and this was always in her. It's called a lithopedion. Here, hopefully you guys would go calcifications, and you would see calcifications here, you see calcifications here, and then all you gotta do is just figure out what lives there. What lives goes from the left upper quadrant across, obliquely down, and then the pancreas. And if you have calcifications in the pancreas, you have what? Chronic pancreatitis, absolutely. And here is the ERCP showing all these filling defects in the dilated, irregular pancreas with dilated, blunted branches, and there's some narrowing. This is classic for chronic pancreatitis. This is a pelvis, and you see all these calcifications down in here? You see all those calcifications here? Is this a male or female, do you think? It's a male. Look at the shape of the pelvis. Very narrowed pubic symphysis angle. Women have to have a bigger one because the head may come out of the female, the baby, when they have a baby. A male is like that. So what lives where these calcifications are? The prostate. This is chronic prostatitis. Just like chronic pancreatitis, this is chronic prostatitis. You can diagnose that on a KUB, on a pelvic x-ray, and you should be looking for it. These are vascular calcifications in the iliacs. Residents, when you guys dictate like a chest x-ray and they're middle-aged to old, don't say the bones are normal, because the chances are there's degenerative changes of the AC joint. Chances are there are degenerative changes of the spine. Very few 50, 60-year-old people don't have a spur or narrowed AC joint. Very few. So when you say normal, that's not normal. Is it significant? No, but you shouldn't say normal. You could just say degenerative changes of the spine and shoulders. A lot of these older people will have mild degenerative changes of the hips too, little tiny osteophytes. This patient has fractures, but that's not why I'm showing you this. I don't know if I have a, let me see. What do you think this is right here? Do you think those are vascular calcifications? No, this is a male.
Spermatic?
No. Vas deferens. And so what does this patient might have? Good chance it might have? Diabetes. So when you see vas deferens calcifications, the vascular calcifications usually come like this to go to the femoral, and then come like this to go to the internal. Not like this, symmetrically like this. These are vas deferens calcifications. You got to really worry about that the patient has diabetes. Like if you saw fallopian tube calcifications, you'd be worried about that too. So those are stones. Now we're going to go to bones. Hopefully you would know, this is contrast, but you would look, what do you guys notice about these bones? Are they normal? No, what's wrong with them? There are multiple what? Lytic? Well, mainly blastic, more blastic. There are very dense blastic lesions involved in the proximal femurs, the pubic bone, the pubic bones, the ischium, the iliac bones. Look at this vertebral body. This height is bigger than this height. So this is collapse on this side. So this is blastic metastasis. And the differential for blastic metastasis are 5 B's lick pollen. B's are breast, bronchus, special area carcinoid, breast bronchus, bladder, transitional cell, breast, bladder, bronchus, brain medulloblastoma, and I think the other B is, I already said bladder, bowel. And then lick is lymphoma, pollen is prostate. How does the prostate cancer go to the lumbar spine so often? How does it get there? What's it called? Batson's plexus. Absolutely. If you guys, this is nothing to do with this, but If you had a patient with testicular cancer, and I said, I'm only gonna let you order one study, and it can't be a CT chest, abdomen, and pelvis. Is it the CT that you want to do a CT of the chest? Do you want to do a CT of the abdomen, or do you want to do a CT of the pelvis for testicular cancer? Abdomen, because it goes to the periaortic lymph nodes. It drains that way, so it will not go to the pelvic lymph nodes and the inguinal lymph nodes. It's going to go to your periaortic, so you want the CT of the abdomen. They're going to do abdomen, pelvis, and chest, because we know Lance Armstrong had all those metastases from seminoma, huge adenopathy, pulmonary metastasis, brain mets. But he really went down in shame. That's sad, because he was like a hero, but he's no hero anymore. Okay, this, what do you see? Multiple what? Black hole. Look, black hole, 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 big black hole, black hole. What do you think this patient has? Mets myeloma lymphoma. This is multiple myeloma. If the patient has multiple myeloma and we order a nuclear medicine bone scan, is that a good study to order? No, you order a bone survey. We hate bone surveys, but that's what you have to do. If this was, they were worried about a metastasis, which primary malignancy is almost 100% lytic?
Kidney.
Renal. Here, this is a big lytic process. Patient had a right total hip arthroplasty. What do you notice though about the bones? Are fused. Very good. What else do you notice? SI joints are fused. What is this? Ankylosing spondylitis, absolutely. Ankylosing spondylitis will not be in your cervical spine without being the rest of your spine and SI joints. It starts at the SI joints, they fuse, and then you get, this is called the what? Bamboo spine. The bamboo spine, ankylosing spondylitis. If you have sacroiliitis, if I just asked some of y'all this earlier, we have a lower half of the SI joint, we have an upper half. We have an iliac side, we have a sacral side. Which side and which half does sacroiliitis the worst? Ilial or sacral, upper or lower half? Two-part question. Younger residents?
Well, I guess I got a 25% shot at this.
You get, okay, go ahead. You got 50-50 for the two-part
No,
question.
but I gotta go lower or upper, so that's 25.
For the two-part question, you got 50-50
Okay, so I'm
for
gonna go sacral lower.
sacral lower, 50%. Carson, I'm not gonna tell you which 50% is correct. You say upper sacral?
I guess.
0%. That's okay.
Maybe choose.
That, no,
I was gonna go
Carson,
sacral lower.
that's okay. It's ilial lower.
Okay.
Ilial side is worse, and the lower half, because that's an actual synovial joint. So the lower half and the ilial side are usually worse than sacroiliitis. Do you guys notice anything on this?
Yeah, pelvic pressure.
No pelvic fracture. Where do you see a pelvic fracture?
Oh, never mind, it's just the wing, sorry.
No bottom of the sacrum. This is partial sacral agenesis. And sometimes, let me see, can you call 31110? 31110. Sometimes the hardest thing to find is things that are supposed to be there that aren't there. I was at a conference once and they showed a chest x-ray and they go cough. And this person had no left clavicle, no scapula, no left arm, and people didn't see it because they were looking at the lungs real hard for a pneumonia or something. If you have something that's not supposed to be there that is there, that's easier. You go, what's that huge thing? But if you did what I do, sacrum, you'd come here and say, where's the rest of my sacrum? Where's my sacrum? There's a lot of stool, but you can always see through it. You can see some of the bone. There's nothing here. Sacral agenesis. This patient's mother might have been diabetic. Okay. Do you guys see anything here? This is not the bone, but this is what? Calcifications from what? Chronic prostatitis. What is this thing? called a pelvic digit, because it looks like a digit. But these are, and this patient has sacroiliitis. Look at this right side. Look how this is really sclerotic. This side's sclerotic too, but this is a lot more sclerotic. This SI joint's more narrowed. It's more irregular. There's probably erosive changes. When you have unilateral sacroiliitis, does anyone know, Piyush, do you know what causes unilateral sacroiliitis? No, that's Reiter's which they've got rid of Reiter's now because he was a Nazi. Reactive, but it pisses me off because I never once thought Reiter's syndrome and thought, I wonder who this Reiter fellow is. I always thought can't see, can't pee, can't climb a tree. So no, that's bilaterally asymmetric, as is psoriatic. Trauma, that makes sense. You had trauma here, you're gonna get degenerative changes, sacroiliitis. Gout, infection. The bilateral symmetric are rheumatoid, ankylospondylitis, inflammatory bowel disease. Bilateral asymmetric could be rheumatoid, but it's psoriatic in your, what is it called? Reactive arthritis for Reiter's. And this is a pelvic digit. They wouldn't do anything about this unless it was causing like nerve impingement or something like that. So we talked about stones and bones. Now we gotta look at mass. You won't see the mass, you're gonna see the mass effect. And then you gotta put two and two together where it would be. If you looked here, there we got NG2, we got the stomach, we got bowel, there's a little baby. But look at this. There's no bowel. Why isn't there any bowel gas over here? Why don't we see the right colon? This is not a 0-day-old. Why don't we see the right colon? Why don't we see some small bowel over here? Because there's something white that's living in here pushing everything over. This is hepatomegaly. It's a huge liver. In this case, this is too white right here. The splenic flexure should be higher than the hepatic flexure. This is down lower. This is a big spleen. Could it be, if it was trauma, it could be a big old splenic hematoma. It could be an abscess. It could be any left upper quadrant process. So if they wanted to figure this out, you could do a left upper quadrant ultrasound. But this was a big spleen. Here, do we have anybody that's really good and notices something really subtle? It could be a senior.
The bladder is collapsed towards the middle.
The bladder is collapsed towards the middle?
Well, sorry, bowel gas. I don't see the bladder.
Which bowel gas is towards the middle?
The right, and it's supposed
The right colon is filled with contrast, and it's too far medial, correct? Is that intraperitoneal or extraperitoneal? The ascending colon? Yes. So ascites or something like that would not move that medial. So there has to be something, and if you look, there may be a little bit of gas here and some swelling. Something retroperitoneal is pushing this. Very, Piyush. Sorry about that. Piyush. Good job, Piyush. So what would you do? CT him. And look at this thing, pushing that cecum and the ascending colon. This was a huge hematoma. I think they may have been on blood thinners, and just minor trauma can cause big time bleeding. But get this here's the descending colon. The ascending colon should have been about the same level. This is too far medial. It's not centralized because of ascites. Ascites is intraperitoneal. The ascending colon, descending colon are retroperitoneal. So this cannot be due to that. It had to be due to some retroperitoneal process pushing it. Now we go to gas. Bowel gas in an adult and teenagers, they're adults. They have the mind of a child, and but they have the body of an adult. And in the old days, heck, people lived to be 30 and 40 and they died. People were getting married at 8, 9, and they had, you know what I mean? So they have the body of an adult, but back then they were a lot more mature. Nowadays, I'm not very mature, and so I'm 53. But so here we go. Is this a KUB or is this an erect view? It's a KUB. KUB. There's no air fluid levels over here in the stomach. This is the stomach. You'd expect to see an air fluid level like here in the stomach. So it's not. Please, guys, when you dictate a KUB, there's one standard that you guys sometimes use that'll say a KUB. It'll say no pneumoperitoneum or air fluid levels noted. You will never see an air fluid level on a KUB ever, because how can you? You do a cross-table lateral, you'll see it. You do a decubitus, you'll see it. You do them standing up, you'll see it. On a KUB, look, there's air fluid levels in this dilated small bowel, but we see no air fluid levels. So on a KUB only, do not put no air fluid levels because you have no idea. So here we have dilated small bowel. We have the valvulae contiventes going all the way across. We know this is a small bowel. It's more central where small bowel lives. In little babies, it can be so tough to tell, is that small bowel or is that colon? It can be so tough. Very, very difficult. But here, there's very little, look at the colon, descending colon. Okay, if you have a small bowel obstruction, usually there's no or very little gas in the colon. But if it just happened, there will be just as normal gas in the colon as there is. So if you see the entire colon with gas, but you see this, it could very well be an early, complete small bowel obstruction. It just hasn't had time for the colon to clear. Do you see what I'm saying? If this has been, the pain has been for a long time, there should be less and less gas in the colon. But if I grabbed inside you right now and squeezed your terminal ileum, you have a complete small bowel obstruction, but I promise you, you have air and stool in your colon. So here's for like I was talking about adults and teenagers or adults, is a rule of 3 on a KUB. If they did if we did some, upper GI and we gave gas crystals, or you did a enema, or they did a colonoscopy, now it doesn't work because they distended it. This is on a person that just comes in, they do a KUB. The rule of 3, the small bowel should be no more than 3 centimeters in diameter. The colon should be no more than 6 centimeters in diameter, except the cecum and ascending colon proximally can be 9. So 3, 6, 9. If you have a distal colonic obstruction, what's going to perforate? The cecum. That's why if they have a distal colonic obstruction, they can't put something like a stent, like with Dr. D's lecture, they can do a cecostomy. They have to relieve that pressure. The cecum is what's going to get, everything's going to get huge, but the cecum is going to get massive, and that's going to pop. So here, we have air fluid level. We do the erect view to look for free air. There's no free air. Always play with your window and look here. Make sure you look at the lung bases. We have multiple air fluid levels in the small bowel. We have very little gas in the colon. This is a classic small bowel obstruction. Classic. This is near and dear to my heart. I love this patient so much. I really do. This was my son. This is the second year med student in Galveston. He was June, July, August, September. He was like 3.5 months old. I was at the A5P. My wife came to visit me. She flew up. His name was Ryan. When I got back from class, she goes, Ryan's throwing up and it's yellow. So I called the Air Force lady that was in the AFIP, and I said, because I was Air Force, and I said, do you have any doctor's name? She gave me her pediatrician. He goes, it sounds like a virus, gastroenteritis. I said, this is bile he's throwing up. They go, just NPO him. In the morning, try Pedialyte, and if he still throws up, come see me. The next morning, he was playing and everything. He'd drink Pedialyte, immediately throw it up. So we brought him to the hospital, and he goes, well, he looks good. He's not dry. And so he goes, let's see Pedialyte. He threw it up. He goes, ooh, he's going to get dehydrated. So they admitted him, and Stephen, the orthopedist intern, was with me, and I had to take him home to take a nap. When I came back, I said, where's Ryan? And Cheryl said, they did an x-ray, and they said my hands were in the way. So they lied to her. They wanted more x-rays because this is what they saw. This looks like the left hemidiaphragm, but look at all this. This is bowel gas. This is the diaphragm's down here. This is a botulate hernia. It's pushed the cardiac silhouette, the thymus, way over here to the right. The good thing, and thank God for, is that this happened. The good thing is it didn't happen here in Shreveport. At that time, there were no pediatric surgeons. There were none. So I was up there at Washington. There's a big children's hospital. This guy, the pediatrician, another thing about on-call and at nighttime techs. Up there, we were at Holy Cross Hospital. The pediatric surgeon from Children's came and said, let's do an upper GI to prove that it's a botulate hernia. So we gave him the contrast. Ryan drank it. It went to the stomach, went to the duodenum, and the small bowel came all the way up here. And when the radiologist, the tech ran the images, it was on those old, remember those old little tiny ones? Black as stink. Couldn't see anything. Couldn't even bright light it and see it. So what does the radiologist do? We have to repeat this. I said, you're not repeating and radiating my son again. I looked at the surgeon. I said, did you see what you need to see? And he goes, yeah. I said, he's got a botulate hernia. He needs to be operated on. So they whipped him down to the ER. we all know at nighttime we have to do a GI study is bad because they don't know what they're doing. Same thing as on the weekend. So usually a Bachlet hernia is going to present in utero, and the bowel goes up into the left chest, so the left lung will not form. The heart and the mediastinum go over here to the right, so the right lung won't form. So most of these babies, unless rarely they're at a real high-tech place that does intrauterine cardiac and chest surgery, the baby is going to come out, it's going to have bilateral pneumothoraces, hypoplastic lungs, and they're going to die. But the surgeon operated, and there was a little hole. He thinks that the spleen was blocking it in utero and for the first 3.5 months. And you know how you go on the airplane, your ears pop? Because it's not pressurized to here, it's pressurized to a certain altitude. He thinks that pressure, the difference in the atmospheric pressure, the altitude, moved the spleen, let the bowel go up. So this is that. Here, do you guys know what this is? This is an umbilical hernia. They're usually in African American children. You guys, every student in here, every resident, they can have huge ones. Sometimes they'll regress on their own. They're never going to get incarcerated because the opening, there's not a tiny neck. It's huge. Bowel comes in and out. You do a lateral view of the chest or a lateral view of the abdomen, standing up, you'll see the bowel gas in that big old hernia. So that, you'll see that, and sometimes people will think that's another type of mass or something. That is an umbilical hernia, usually African American babies. This liver is generous, but we're talking about gas right now. Do you see any abnormal gas? Look at that. Piyush is like on fire. Piyush, good job. Don't forget to look for, in the groin area, for inguinal hernia. There's no bowel obstruction yet, but there could be. This is an inguinal hernia, very significant. The most common causes in all people of a small bowel obstruction is an adhesion. But if there's no adhesion, then hernias are a big cause. So good job. Does this look normal? I hope you say not. The colon is massively dilated. What do you notice, Yemisi, about the colon? What's it called? Look at that. All these little air bubbles. This is erect. This is not an erect view, but look. All these little soap bubble pattern. That's in the front of the wall or the back of the wall that you can't see. This is significant. This could be due to ischemia, infection, infarction, previous instrumentation, colonoscopy or vigorous periminima. Could have had a pneumothorax, pneumomediastinum. Could have had be on an ET tube and vigorous intubation. So this does not necessarily mean infarcted. If it's an old person, chances are they got infarcted gut. In the NICU, they could very well have NEC, and that could be ischemic or infarcted bowel. But you can't, always look for pneumatosis intestinalis also. This is very important. First years, don't look at this one, you've already done it. But you should, they're gonna, the NICU is gonna have a KUB. These babies are gonna be on their back. And you've got to recognize this continuous diaphragm sign. And you've got to know that the liver should be here and should be white. The liver is white. This is white, but what color is this? This is black. This is too dark. We don't see the falciform ligament sign, but sometimes you'll see a little white line here. That's the football sign, the falciform ligament with air on both sides of it. When you see this, you call them up. This is elongated. This is not a normal NICU bowel gas pattern. This is elongated bowel. The bowel gas in a little baby and neonate should be little cubes, little cuboid, meteoric gas pattern, not elongated bowel. And this is, for a little baby, this is dilated. This is definitely not, that's why it doesn't work on babies, the rule of threes. This is dilated, elongated bowel. In this NICU setting, this is NEC, and now they've perforated somewhere. You see this, you call the NICU up immediately. You talk to the doctor, you tell them the baby's perforated, they need consult surgery stat, and go ahead, and because a lot of times the surgeons might not be as good as us seeing this, especially if it's more subtle, tell them to do a left lateral decubitus. You need to say, don't say do a decubitus view of the abdomen. You say do a left lateral decubitus of the abdomen, right side up. And so you tell them left lateral. Left lateral means left side down, right side up. And here's a cross table lateral view. This is the liver. This is the Wriggler sign. You see the inside wall and you see the outside bowel wall. You could measure the bowel wall thickness. You should never be able to measure the bowel wall thickness. Be careful. Don't call this double wall sign because these are just two bowel segments laying beside each other. But this is the double wall sign. This is a large amount of pneumoperitoneum. If you ever in question, call them up. Just tell them get a left lateral decubitus. They'll do it. We got to run an NEC up there in the NICU right now. Dr. What? KUB, Dr. KUB, K-O-O. He's back there, he knows. Do you see this gas? Where's this gas located? It's not rectum. Rectum would never look at. Look at the CT. It's in the prostate. So is this an infected prostate with a gas-producing organism, or could this be a TERP? Could it be a TERP? Sorry, Dr. KUB, I drew a blank, had a brain fart. Here, there's a NG2 of some sort, contrast in the gastric fundus. Do you see any abnormal? Excellent. There is lucency in here. Some people could say, well, that might be the duodenum, but look at this. This is an organ, and this is air in the wall of the organ. Are these patients usually sick?
Very sick.
Very sick, very sick. Could get septic and could die. So emphysematous cystitis is very important. This is the rectum. So what is this gas in? The bladder. And what are these little black circles? The same thing as if they were in the wall of the bowel. This is pneumatosis of the bladder. So emphysematous cystitis. Are these patients deathly sick? They're not deathly sick, no. Diabetes, but not deathly sick. See all the little tiny little circles? Those are little cystoides. That's what they call them, pneumatosis cystoides. They're little round collections of air in the wall. Miscellaneous. Anybody know what this thing is? It's a donut, but it's not a donut, but it's a donut shape. It's a pessary. Pessary are for women that they have uterine or vaginal uterine prolapse out of their vagina, usually because they've had multiple babies. Their pelvic floor is horrible, very weak. But then look at this. This patient has DDH or chronic dislocations of the head with very abnormal acetabuli. This person's probably not walking around very much. It's a pessary. These are vascular calcifications. There's a right femoral venous line. The femoral arterial line will always be a thin little line, and it's going to be out here. I guess it goes vein, artery, nerve. In interventional, you need to know that because if you have to stick the artery or the nerve, you need to know. But what is this thing?
IUC.
What?
Looks like an IUCD.
IUD,
Yeah.
intrauterine device. If they want to know where this is, does this tell them where it is? No. What do they need to do? Ultrasound, because that can migrate out, that can perforate. So we want to make sure it's in the endometrial stripe. But this at least shows you that it's in the midline. But correct, we don't know where exactly, you can't say where it is. What are these things, interventional people? Biliary stents. Everybody, students, do you guys in the back, you know what this is right here, students? Students? What structure does like this? Look, comes here, and then comes up here to go to the heart. The aorta's on this side. So the inferior vena cava. So this is the inferior vena cava filter. This is an IVC filter. And I don't see the little hooks for retrievable or not, but when I was a resident in Dr. Nall, it was always a greenfield filter we put in. They may have put bird's nest in, but I never did. It was always a IVC filter. Don't you hate those commercials of those lawyers? They say, did you have an IVC filter that migrated, or you die with an IVC filter, or it broke off? Call us and we'll sue the doctors and the company. The patient may have never made it to have that thing break off if they didn't put it in, because they would have died of a PE. But lawyers will sue about everything. Here, this is dilated small bowel with air fluid levels. So you think it's a small bowel obstruction? There's a cause for this small bowel obstruction on this radiograph. Where?
Connected over the right
Yes, so what is this?
Gallstone
Gallstone ileus. I don't show it, but it could be air in here. If you see air in the biliary tree, and you see this, really look over here for a gallstone. Where's it stuck at? The ileocecal valve. It couldn't go through it, so it causes small bowel obstruction. On your test, if they ask you, is biliary air more central and portal venous gas more peripheral? That's correct. But when you see the NICU babies and they have portal venous gas, it's going to be more central and branching. I don't know why, but it just is. But biliary air is central, portal venous gas is usually peripheral. And there's really no reason for a little baby to have biliary air. So if you see in the liver, it's probably going to be portal venous gas, and that's from like NEC. And when I was a resident, that was a sign of impending death, but now it's not. This is a swallow. This was a prisoner. Razor blade. This patient swallowed a razor blade. A lot of times they'll put tape on the edges or gum or wax because they don't want to cut their mouth, but they want to make it look like that they really are mental. They need to be in the hospital and not in the prison because they don't. That's a razor blade. Here we have all kinds of foreign bodies. What is this thing?
Monopoly.
That's the wheelbarrow in the Monopoly game. So this patient is probably a real poor sport and probably landed on someone's boardwalk when they had all these hotels on it and just grabbed their little wheelbarrow and swallowed it and quit. I don't know, that was just a good story. Look at this person swallowed all kinds of stuff. I don't know what, this is a bottle cap. I don't know what all these things are, but people, we have a patient that swallowed a lighter. GI went in there and got the lighter out, cigarette lighter, and then she asked the nurse, can I go outside and smoke? And the nurse said yes. So she came back with another cigarette lighter that she swallowed.
She asked a med student.
Is a med student let her go?
My class, it was Jackson.
And he said, go out and smoke. And so she smoked again. So she smoked and then swallowed her cigarette lighter. So this person has bullet fragments, multiple, and a retained lap sponge. This, students and residents, this is the blue part of the sponge. You can't see the sponge. You see the blue part, which has metal in it, and that's why they have it. And they do the lap count, and they have that blue part with metal so we can see. That's what a lap sponge looks like. You got to make sure you don't call that a drain. If you think that could be a drain, call up and say, does this patient have a drain in the left upper quadrant? They'll say no. Then you say there's a lap sponge in there. It can cause a reaction, can cause perforation, and when it causes a big mass, it's called a gosioboma. Textboma or gosioboma. This patients, if there's an opening in your body, patients will put things in them. This, yes, one in a million. I fell on it. This was a Louisiana hot sauce bottle.
I thought it was a beer bottle.
So case one, does anybody see any abnormality besides eclipse? Maybe a little atherosclerosis, degenerative changes, atherosclerosis. I'll tell you, so the pelvis. Anybody see anything wrong with the pelvis? Justin?
Yeah, looks sclerotic left more than right. Fracture.
What is this? So you said this looks normal except for here. This is too white, is it not?
Yeah.
What about this?
Cortical thickening and
Paget's disease. This is Paget's disease. This is the iliopectineal line. This is normal. Look at the thickness of the cortex. Look at this thickness. Look at these trabecular markings are coarsened and thickened. This is really white. If you see a vertebral body and it's bigger and white, that's Paget's disease. Paget's disease enlarges bones, causes increased density, whiteness, and causes coarsened trabecular markings, but they're weak bones. It's an osteomalacia. This is Paget's disease. What else I was going to say? Blastic metastasis to the vertebral body would cause a blastic body, but it would not make it bigger. Paget's disease can. PEDS never gets Paget's disease. Okay, anybody, there's an NG tube here, we got some contrast here.
Porcelain gallbladder.
Porcelain gallbladder. Look in the right upper quadrant, we have this thin, curvy linear calcification right in the shape of a gallbladder. Is this, what kind of patients usually get this? What demographics?
I'm gonna go with female.
Female and probably older. Why do they take this out?
Cancers.
It can turn into a cancer. It has a great chance later on to turn into cancer. Are there usually gallstones with this? Yeah, they usually have some gallstones. But that's a porcelain gallbladder. Here's what it would look like on ultrasound. You would see, it could be tough. You could say, well, you know, there's a lot of shadowing, but we don't see the stones inside here. So it has to be coming from this. This is shadowing from this. You could say, well, could this be the wall echo shadow? But here we see the back of the wall. Wall echo shadow, you usually don't see the back. What does wall echo shadow mean?
Wall echo shadow complex.
Yeah, what does that mean?
There's so many, the gallbladder is so full of gallstones.
Completely filled, or is a contracted gallbladder completely filled and all you see is the gallbladder wall, the anterior part of the wall echo is the stone, and the shadow is the shadow. This is going to take bone. This is about bones. I want you guys, I'm going to just see who's really bright, who's really sharp. Yes, what? What'd you say?
Yeah, pedicle is missing.
Missing. Do you remember I always go pet, 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 pet. Whoa, there's not a pedicle here. Excellent. And all the residents always make fun of me when I go black hole, black circle, black hole, or black or white tumor, black or white mass, and or pet, 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 pet. They make fun of me. Britt Somerville did the same thing. And one day, like a couple years after he left, I got a text. He goes, Dr. Gates, your ped worked. He said, because he was working in teaching, and he said, if I had not done your ped, I would have missed a missing pedicle. This is a lytic pedicle. The differential for a lytic pedicle would include a lytic metastasis, osteoblastoma, and aneurysmal bone cyst. That's your differential for a lytic pedicle. But that was all off of this abdomen study. You know what I mean? The clinicians are just looking over here for, is there any bowel obstruction? That's all. They're not expected to see that. Are you? Yeah, because you can get sued for missing it. You could get sued for missing a lung cancer right here. When you do a shoulder x-ray, ortho is great, but they don't know they don't really look at lungs. They don't look at for pneumothoraces. They know how to look at bone. And so what can cause shoulder pain? A Panco's tumor, a pneumothorax. So we really need to be looking at everything, Is I know that when you're if this is the ER and you have 100 studies to read plus 50 CTs that you have to look at, I know it can be tough, but we need to do our best. This is soft tissues, just to try to, in the sake of time.
Kidney large,
Which kidney?
the right,
So you're saying this is the right kidney right here,
yeah,
and this is the left kidney right here?
yeah.
Is that normal axis? Here's the psoas muscle.
Okay, so it's pancake fused.
No, don't say pancake. Pancake, that fuse here, fuse here. Horseshoe kidney, horseshoe kidney. And there's the horseshoe kidney. What's the problem with horseshoe kidneys?
Stones,
Stones,
cancers,
infection,
trauma.
stones, infection, and trauma. Especially if you're thin, I'm not, but I punch you or kick you right in the midline, and my fist goes between here and the spine, you could fracture that kidney. You said tumors. What kind of tumors? They do increase risk of like Wilms tumor and probably renal cell. And what other association? Who else gets these? They get coarcs, cystic hygromas, Turner's. Turner syndrome, increased incidence of horseshoe kidneys. So that was all. Please, like Dr. Nall, I have begged you guys, please look at the plain films. You can diagnose a lot off of plain film. You can diagnose a lot off of plain film.
Thing is they're not They don't do very many.
You're
The only
right.
ones they do are for tube placement.
So that's going to be the majority of your studies in private practice. The majority of the studies are plain films. So you should be very comfortable with plain films. Thank you, guys.